All right. Hi, everyone. Good morning. Looks like we have a lively crowd this morning. My name is Agnes Buena. I am your moderator for today. I work for Care First Blue Cross Blue Shield. I'm a population health manager there, where we really focus on how to lower the cost of care, improve quality of care by implementing population level strategies. So I am excited to moderate this panel today, which is focused on how we can actually utilize AI, predictive analytics, to actually, drive improvements in patient population management. I have a wonderful group of panelists over here that I'm going to turn it over to introduce themselves before we jump into a lot of our questions. And I do want to give you a heads up that we'll have a lot of time for Q&A. So make note of your questions, anything that's on your minds, and we will spend a good amount of time at the end of this talking through those. So to start off, Kevin, can you tell us a little bit about yourself?
Yeah, Kevin Terrell, co-founder, CEO of Birch AI. We're a spin out from the Allen Institute for Artificial Intelligence in Seattle, which is Paul Allen's legacy fund AI research organization. And we were acquired about 6 months ago by a company called Sagility Health, which is a Indian BPO based in the US, but also has a large technology stack. And so we were kind of brought in to help accelerate what we're doing on behalf of payers and providers from a technology perspective and infusing generative AI and AI solutions in general into what we're offering customers. My background started my career actually right down the way here in the Navy Yard with the Defense Intelligence Agency and CIA. And so I'll preface it with this, which is, back then I was literally the AI. So what am I talking about? So, FIBIS for CIA published 33 reports a day, basically, on foreign broadcasts. And they didn't mine them at all for intelligence purposes. So I literally read every single report every single day, summarized it, and then fed it to different analysts. And in a year, generated more reports than entire branches of people, just doing something that simple. Now you can do that with a couple of prompts in a minute, right? So just, amazing improvement in terms of what's possible, in terms of understanding unstructured data and applying that to a problem. And so the premise behind Birch really was healthcare. One of the major problems, the reason you don't have productivity is because there's so much unstructured data, whether it's audio or documents, and you have lots of expensive people spending a lot of time interpreting that so you can do something with it downstream. And so what we did was apply generative AI, wasn't called that then, to that problem. My healthcare background, McKinsey's global healthcare practice, and then consulting for a number of years before co-founding Birch.
Thank you so much. Dipti, why don't you tell us about yourself?
Hello, everyone. Good morning. I'm Dipti Batina, founder and CEO of RhythmX AI, and lots of scars on me for about healthcare from various different roles through the decades. And the premise of my why I'm doing what I'm doing goes back to, in my childhood, I grew up in a very small town in southern part of India where chronic conditions that are well known now, like diabetes, due to lack of awareness and due to lack of accessibility to proper treatment, I've seen my own family members, like my grandmother, suffer. Her leg got amputated because of advanced diabetes at mid-60s and shortly passed away after that. And it always impacted me. And as I was growing through various healthcare roles, I had an opportunity to visit public-private hospitals all over the world, ranging from South Korea, Japan, Germany, Brazil, all over the world, including US. And I've seen a lot of suffering, lack of access throughout. And where we are with technology now, Symphony AI Group funded our company, RhythmX AI, $50 million initially, backed by additional $1 billion into AI. And they've been in the space long before AI was cool. And my personal belief is that technology to me is magic. The first time I coded 30 years ago, I'm like, wow, is this magic, right? And if I look at where we are the last even 12 months, right? The way AI is changing at a warp speed, it's mind-boggling. It used to be at a high school students level caliber last year. A month ago, I would say AI was more as an undergrad level. I just got my briefing a week ago because all CEOs in our portfolio companies get advanced briefings about OpenAI's OpenAI's O1 it's now beating PhD experts. You don't even need that much data anymore because already we are getting out of the era where you needed a lot of data and the bigger models were smarter. No, we are now at the verge of an era where deep reasoning is in our hands right now with far less data than you could ever imagine and seriously beating PhD experts. And to me, we have the moral imperative. The people in this room have the moral imperative to embrace these latest technologies to solve for some of these deepest healthcare problems.
Oh, thank you. Joe.
Thank you, Agnes. Good morning, everyone. I'm Joe Kimura. It's a pleasure to be here, and thanks to be invited to be part of this conversation. I'm the Chief Medical Officer for a company called Somatis. We're in the DMV area, but we're a specialty-based, value-based care company, and we focus on improving population health outcomes for folks mostly with complex kidney and cardiovascular conditions. And I'm a primary care doc by training. I'm a clinical informatics guy, and I've been spending 20 years of my life really trying to push how population health as a construct is really trying to help eliminate a lot of the inequities in care. And Dipti mentioned the international scene, and I guess one of the questions we were asked is the why am I so passionate about this? When I was coming out of clinical training in 2003, Beth McGlynn published that New England Journal article on quality of care, which, if any of you guys have seen it, is like horrifically embarrassing for the United States, right? 54% of Americans got evidence-based care at that point in time. And the follow-up in 2020 still says, we still suck at this. So to me, the aspects of we know what to do, but somehow we are struggling to get that to every American that deserves that care, and every American absolutely deserves world-class care. How do we do that? And I think the tools we're talking about now are going to help us overcome a lot of those barriers around execution to raise all ships and get everyone to a better spot. So super excited about this conversation, and really excited to learn about these two tools. So, yeah.
That's great. Thank you all so much for sharing a little bit about your passions, what's driving you. Well, we're obviously all here because the healthcare landscape is changing really fast. So let's talk a little bit about the challenges specifically that AI and predictive analytics are really here to help us solve. And I'll start out with Joe, and I believe you have some slides for.
I don't have slides for you. Kevin would have slides.
Kevin, there we go.
Yeah, can you just pop that one slide? Yeah, so just a simple framing of the problem from our perspective, and this isn't all inclusive by any stretch. But 65 does not equal 85. What do we mean? The population is aging very quickly. Caring for someone at the age of 65 is very different than caring someone for at the age of 85. And at the same time, 7 does not equal 3, just speaking to the ratio of caregivers to people needing care, right? You have this explosion in terms of the number of people who are 85 years old, while we have a shrinking population of people to help them, right? So this problem is going the wrong direction. And the bottom half of that, 0 equals 0. Point here being that if the patient or member doesn't engage with you, you're not going to have impact, right? And then the point is that push does not equal pull, talking does not listen, right? So we're always trying to push things at people, right? But people don't want that. They want you to pull information from them. And so instead of talking at them, we need to listen to them, right? And what, as I alluded to before, what generative AI is allowing us to do is to listen at scale, semantically understand conversations when they happen at the member or patient's convenience, extract, if you will, information from that, tie it to all the other data that we have. And of course, there's lots of issues with tying to the data and such, right? But we can see where it's going, right? Generative AI plugs into that and allows us to then start to come up with a better picture, and we can go to the next slide, of what the member or the patient actually looks like. Can we advance one slide? Yeah.
Think I can. Nope.
But yeah, the point being that historically pre-generative AI and pre-being able to understand these conversations or documents live, everything we were doing is manual, it's coarse, it's Control F. And what this new generation of AI allows us to do is, again, understand conversations, documents, and such at scale semantically, get a fine-grained view of what people, patients, members look like, and then start to act accordingly. So feeding all that into from a population health perspective, and then particularizing it to the individual. Right? And so that's what we're working on at Sagility, and that's what Birch AI is there to help us at Sagility do.
You did a great job, covered everything without the slide.
Yeah.
Okay, do either of you want to add anything?
Sure, happy to. So as I mentioned earlier, and agree with Kevin here, is that if you think about the power, I always say problems in healthcare are not new. I could talk all day about what the problems are. There's workforce shortage, aging population. I used to be the chief clinical product officer of Humana. I see several of my colleagues in the audience here. And some of the problems we dealt with were from 25 years ago, 50, 100 years ago. If it's that easy to solve, we wouldn't even be here today. To me, it is about the shift that we have to come together culturally, mindset-wise, technology. A lot of things have to converge to solve these problems, right? And what that means is, think about the most powerful evolution that I'm talking about happened like literally days ago at this point, the deep reasoning power, right? AI at this point, based on the briefing like from a couple of days ago, is launching off into a private chain of thoughts, and it self-corrects itself halfway through, literally beating PhD experts. And I'm like mind-boggled by the power that we are on the verge of getting unleashed. Think of that and apply it to two problems, one at a population level, at an individual level, right? At a population level, the whole reason we even founded RhythmX AI is to apply this powerful AI to be able to think about how do you deliver right care to the right patient at the right time through the right clinician. And it may not even be clinician, by the right profile, through the right channel. Easier said in a sentence, but immense power of what it takes to do it. And then you take a profile, call it primary care physician, right? Because that's where it's starting. Think about what it means there. If I'm a primary care physician right now, you came to me as a patient, imagine I have to look through your year's worth of clinical data, social data, mental health data, or what is your your payer profile, is it covered or not? Covering all these things for hundreds of chronic conditions and acute conditions. Oh, by the way, I have half hour today with you. The cognitive burden is humanly impossible. Everybody talks about administrative burden on doctors, but it's administrative burden, the moral burden, and then there's a cognitive burden at this individual level and at the population level, humanly impossible. And then you have this greatest power of AI that's evolving. That's where we have to bring these things together. But what's missing is AI, even as of today, is thought of a tool by most people I've met. The time has come for us to think of as AI as a collaborator. The role of AI is drastically changing as how do we bring human ingenuity, compassion, with extremely powerful AI as a collaborator. The organizations who see that and embrace that are going to move forward faster, and the ones who still think of it as a tactical tool will pay for it.
Yeah. No, it's a great point. And I think for me, the place that I would add to the construct Kevin presented too was, as that demographic is aging, we know like that disease burden, all the complexities are there. We've all seen that bell curve shifting. I think the CDC just said like half the states have a third of our citizens that are now in the BMI space, not the BRI yet, but BMI. And so we're expecting more and more deterioration clinically of that population if we're not jumping ahead and being more proactive about preventative care that we know works. And I think the part that I would say that we should talk about in this construct too is execution and bringing that to the actual patient itself. Because I 100% agree, there's a ton of things that we know should work, and somehow we are tripping over ourselves getting that to patients, right? And I blame doctors, right? We are restricting a lot of the capability that needs to happen because we are holding on to power. We're fighting with APPs around what they can do, what we can do, what can pharmacists do, what can nutritionists do, and ultimately, what can patients do from themselves, right? With these kinds of technology, that democratization of medicine will be transformative, and that's the only way we're probably gonna hit that curve. But I'll just put one last plug as we move into the discussion is, The financing model also matters, right? And I think at the end of the day, to me, I think about value-based accountable care intersecting with population health management, the clinical models, then intersecting with these super powerful capabilities. And it's a transformative moment. I will agree 100%. I am super excited about what the possibility of future is as these things come together. But, we got to get all three of them going.
Right.
So,
Yeah.
So, yeah, I think everything that everyone said definitely makes sense. I feel like in my experience so far, a lot of the positive, progress that we're making is in being able to add in some of that qualitative data, right? Real time, being able to better understand what is influencing the care that individuals may or may not be receiving. So definitely we have a lot of work to do, but a lot of progress so far. So shifting a bit, we've talked about the challenges, what we're here to solve. Let's talk a little bit about what we're doing so far. So tell us a little bit about the achievements that we're seeing so far in AI and predictive analytics utilization. And actually, it sounds like, Deepti, you had a couple of thoughts here to start us.
Yeah. So some of the areas where we are seeing in general in the industry, and I'll also speak about the gaps we're seeing, right, is with each passing year in the last few years is with respect to predicting, if you took the entire population, I'll take Medicare population as an example, right? It would become a pyramid. You're sickest of the sickest at the top. Think of it as healthy but at risk at the top. Maybe they have one monochronic condition kind of thing. What you'll notice is, irrespective of what condition you have, you could have diabetes, you could have CKD, hypertension, doesn't matter what chronic conditions, there are three things which we call the accelerators. If you have a clinical condition and one of these, you can predict, but these people will start moving to upper cohorts much quicker. And even if you pause them in their current cohorts, it's billions of dollars saving. And since everybody here is healthcare, I want to give three guesses. What do you think the topmost three accelerators are to predict how people are going to get sicker? Humana people don't talk. Any guesses?
Where they live?
Yes, where they live. I would put it under the umbrella of social determinants of health. You have diabetes is one thing, diabetes multiplied by your social factors. Yes, definitely. Other big buckets. What is it? Age, obviously, as Kevin mentioned. Yep, definitely. Other big bucket is also mental health. If you have diabetes, chronic conditions, it's one thing, but if you have that plus depression, you're going to get sicker faster. Third most important one that impacts everybody. Lifestyle. If you're also smoking, there is obesity issues and a lot of the lifestyle, the way people live. Also, you could have the same exact conditions and you would propel into sickness faster. And the thing is, to be able to take care of these kinds of things upstream, using a combination of generating content, using generative AI, and think about the reasoning about if Joe left today my office, by the time he comes back again, some of the irreversible conditions will progress. He will never come back to me. I'll take CKD as I see my former colleagues as an example. If you came back as stage 3, stage 4, you're going to manage that, but I'm not going to bring you back to 1. And he's going to leave this office in 20 minutes, right? Yep. And this, to me, is where you bring combination of generative AI, the latest power that's changing, evolving every day, predictive AI, all these latest technologies to be able to say, what are the 4 conditions he may already have, but no symptoms? Let me order that lab or medication to get it under control. Or 2 things is, we both know you have these 5 conditions, Joe, yep. But this one, you're going to progress faster because of all of this. Right? Yep. So this complexity to manage when I'm going to see you once a year for half hour, how are you going to do it without using the latest power? And patient is at the center, and we are doing irreversible damage if we don't use technology for it.
20 minutes.
20 minutes, yeah.
So I actually want to pivot a little bit because this is the provider, data track. So let's talk a little bit about how we actually prepare providers for this rapid change that's occurring, especially coming from the payer side, since a lot of payer, mechanisms are not really as focused on AI and its use right now. So what are some things that our provider groups could be doing to prepare to better use AI and predictive analytics? And let's start with you, Kevin.
I think everyone, from a preparation perspective, needs to think about data and access to data and systems, right? So one of the biggest obstacles to implementing anything that we've seen is just the kludge of systems, right? Whether it's, I've got, call center agents with 13 different screens they have to tap into, whether your data doesn't have a key field across it, whatever, right? There's just a ton of data that's sitting there. We're sitting on a mountain of data, but it doesn't talk to each other, right? So start thinking about what your data strategy is and how you start to integrate that, because that's where you get the power. Today, you're relying on someone who's been working this task for 20 years, and she knows everything in the back of her head and knows the customer inside and out. Well, you can't expect a brand new agent or a brand new clinician to know that. But the data is there. You just have to find a way to tap into it. And then the AI, to your point, can start to push it to people in a way, can generate I'm listening to the conversation, I can tap into everything live and present to the clinician, here's what you should be talking about, and do that live in a way that you never could before, but it's reliant on plumbing.
Yeah.
What I'd say is that I agree that it's inevitable that providers are going to have to utilize all of these capabilities to be effective and to be able to get the outcomes that we're all aspiring to achieve. And I think, in many ways preparing them, I think there is so many pain points that providers are facing. In this morning's session, we talked about it. I mean, not just the tyranny of the urgent, crowding out all that great preventative capability, the 20-minute visits in a fee-for-service type environment where you're gunning and churning, all the way to, right, the fact that my team is constantly turning over. My MA is not the same, right? Every 3 months I have a new MA, new workflows, et cetera. So I think there is an opportunity for plans and providers to work to start demonstrating the power of these capabilities. And I think training is a great place to start. I think, two things that I just, my mind is popping on, sort of getting patients activated. We've been talking about that for 25 years, get that motivational interviewing going, get stages of change, blah, blah, blah. It's a technique, it's a skill. People still aren't good at it. And yet we know time and time again, if you get to PAM level 3, 4, way fewer avoidable sort of ED visits and hospitalizations. But how do you do that? Can we use the generative AI capability using audio capabilities to help train clinicians to get better at this, rather than doing the old school way of me as an attending, having to sit, listen to you and be like, hey, you didn't use the right words, you didn't apply the right empathy, et cetera. That's capability that exists in the technology today. We should help clinicians be better at it. Prioritization, I think is the second thing. I think I need help for the complex CKD patient, 15 medications, 25 things on that problem list, and you gave me 20 minutes. Yes, I would love to have technology help say, of the things that I could possibly talk about, what is the patient's most important, what is my most important, and how do I dance together to help advance that care? I think there's a huge amount of opportunity to be able to help and then introduce those capabilities to help the provider trust the technology to begin to use this.
Yeah.
I have a quick question. A show of hands, how many of you are from a health system?
Don't be shy. Yeah.
How many of you from a payer? Got it. To add to both my panelists' points, right, one thing I'm also noticing in the last several months is the fear of the unknown, right? You have people who run towards change, and those of you who read the Jeffrey Chasm's good old Crossing the Chasm, you have your own small group of payers and health systems who are going to be like, I see a great opportunity, this problem has plagued us for hundreds of years, I'm going to apply. And then there is this group of health systems and payers right behind them watching you. If you fail, they'll act like they don't even know you. And if you succeed, they'll be like fast followers. And then there's the nice chunk group of healthcare, by the way, I'm one of you as well, so that gives me the permission to critique, is they will be dragged towards change, kicking and screaming, right? These are the ones over time won't exist, but ask yourselves who you're going to be, right? And in this whole process of you ask what could like health systems do, payers do, is think of it as a quadrant, right? X-axis, think about the number of data fields you give about a patient, the longitudinal records, right? Initially, you start with what's in EHR, and then you add claims, and then you add social data. As you keep moving towards X-axis, think of Y-axis about the accuracy of ability to be 100% right with 100% accuracy all the time keeps going up. We're talking about healthcare people. By the time we go to the top right quadrant, I think I'm going to die, for sure, right? It'll take that long. Don't be an edge case assassinator. I just heard this a few days ago, and I love it to describe. What that means is, while you see so much value your clinicians and care teams can get for population management from a certain technology, you know who you are. I'm looking at all of you who will be like, but hey, these 50 things work, but that one thing, it's not right, it's not perfect, so I'm not going to adopt it. Guess what? Are you going to wait for everybody to die before you get there? And we are already at a crisis in slow motion. So I beg everybody here, please don't be an edge case assassinator. Think of it as how much value would it add? How would you mitigate some risk? Go after low risk, high value areas to embrace AI, and you owe it to the healthcare industry and to the patients.
Do you want to add?
Oh yeah, I love this conversation. So yeah, I think, and the back and forth here, right, is I do think there are services and folks that are doing transformative work, but I think all of us know that the marketplace is flooded with a bunch of stuff that I would say, to me, I call entertainment medicine still. Like it's just, you get like certain adoption, but does it really move the needle on the things that we care about? And so how do we find those things, Dipti, around sort of that high value, sort of those areas that you can really say, yeah, there is some, I don't want to call it evidence because that's too strong, right? And I think, again, the medical profession wants too much evidence before we jump into to try things. And I think this is a place where real world stuff can really make a difference. But that's the area that I struggle with a lot. And when I talk to my colleagues as well, too, it's sort of like, everyone says they can do it, and I want to jump because I'm very optimistic about that. But how do we figure out those areas that can say, like, yeah, this actually really does work, or mitigate that risk? And I think too many of my colleagues will say, like, I've been burnt, right? And so now I'm super skittish about jumping into that space, and then I feel, super disappointed for them, right? Because they're becoming those edge assassinators, right, at that point.
Yeah.
I don't know.
I just have two more questions for the group, and I'll actually start with you for this, Joe. So in 2021, the National Kidney Foundation shifted from the use of EGFRs, the standard for CKD testing, because of its inclusion of race.
Yep.
So how do we make sure that as we are progressing with AI, predictive analytics, with a lot of these innovative tools, that we're accounting for any biases that may come from, socioeconomic, racial, ethnic differences, without slowing the progression, because we do know that there are some influences?
It's a great question. I think the first dose of reality, right, was when FDA published, right, in the 21st Cures, that software as a medical device sort of ruling, at which point people were like, all right, so I'm going to take it up to this point, but then ultimately, doctor, you have to decide if this is relevant, right? At which point that risk then shifts back to the clinician who is overwhelmed to try to make those decisions. I do think there is a good way to begin to be sure that we are refracting the lens around health equity and the blind spots that we have around the data that we're using to generate a lot of these prediction capabilities. And we should develop transparency, right, around how our models are performing in these various areas. And I see the movement happening because I think a lot of people have called that out, particularly in the kidney care space now. And so, we should always be mindful of those blind spots. We will always have them, though, which is the part, Agnes, that I'm going to say. It's a never-ending chase to try to be sure that equity is there along those lines. And I fear, as the tools get powerful, sorry, I said tools, the capabilities get more powerful, and we are able to tap in more areas of unstructured, ungoverned, uncontrolled type information, because the power that gains by getting that breadth, that there is the opportunity for things to get misinterpreted overall. And then if I put my completely paranoid hat on, you think about data supply chain sabotage and people influencing that by introducing things in the data supply chain that will then influence all these models because people are tapping into it. And so I think it's relevant security infrastructure capability, and all these things have to be monitored, but we can do it responsibly. And I think we have to commit to being sure we're saying, yeah, we looked at that, here's what it looks like. And it's not perfect, but we keep going.
May I add to what you say? By the way, every time Joe says clinician, he's showing me I'm not a clinician.
We're all clinicians.
For today, you
That's
are.
true.
In the
Honorary.
future space, we are all clinicians.
That's true. That's true.
Yep.
A few things we are actually, the question you asked is like right on nucleus of what we're solving is, right? Like I said, we're part of RhythmX AI, and we've licensed data for 300 million patient records because of our parent company. I bet, and we all know data has bias. Guess what? It's produced by human beings, right? So a few buckets of things that we're doing is, one is being very mindful, like the example you gave, Agnes, that a lot of guidelines, evidence-based medicine is evolving every day to bring in health equity factors, right? And we are continuously monitoring it and bringing the latest guidelines into our software to say, hey, if race has been included and these tests have to be done with XYZ with this, it'll start showing in our software, because we have to be mindful that those, every day they change, human beings can't keep up, but software can with those changes. And the second big category we're doing is, I used to be the former COO of Walters Clover Health. Up to Date is one of my products back then. Those of you who are doctors love it, so I love to brag about it. Is back then we had 6,000 physicians who worked for me globally part-time. Now what we are doing is we have a team of clinicians and specialists in every condition. With AI advances, I don't need 6,000 people anymore. I'll share the number next year with you guys, but we are building a decent sized team who every day at every stack of the layer working very closely with the AI specialists to make sure the interventions we show factor in and being for responsible AI. Again, do these human beings have bias? Yes. But they're being trained, they have a job to make sure they're trying to mitigate it as much as possible. So you see the first one is latest guidelines changing. The second bucket is every stack, combo of clinical by AI collaboration. And the third thing is, to Joe's point, we are striving hard, took it as a challenge to deliver explainable AI. Actually, the X in our company name stands for explainable. Is don't make it a backlog. Explain to me, why would you say this for this patient? And that's where we are not doing autopilots like car industry. They're already self-driving cars. Why do you think healthcare is not there? Because of all these things, we are responsible, right? Look at it as a copilot. There's always a human eyes on it to say, yep, I see why you're saying it, and I agree. With all these layers, there will still be bias, but we should keep working on it.
Yeah. Kevin, do you want to add?
Well, I'll start off, I'm definitely not a clinician. I was a German political science major with the ever important history minor. So definitely not a clinician. But between CIA and McKinsey, I was at GE. And one of the things I was Six Sigma black belt there, so continuous improvement. And one of the tools that we use there is an FMEA, failure mode effect analysis. Right? And so I think applying these types of principles, that was a services business, but it's a fundamentally manufacturing business. But applying that sort of mindset to AI, to any software development really is a way to have a robust, everyone in the room sort of put your Post-it note on the wall of what can go wrong here and grading that. So having a rigorous approach to that. And then to pick up on something you said, explainable AI, right? One of my pushes back to people is, that's great. Tell me if you have explainable human. You don't. You have absolutely no idea what people are doing at scale, none. Right? So you delude yourself thinking you know, but you do not. And actually what we've seen is that the application of our capabilities into workflows starts to shine a light on that and collects data in a way that you can now start to understand what's actually happening in your operation. So you don't have explainable human, explainable AI helps you get to explainable human and better processes.
That's great. My last question for the group is really around what actionable steps we can take right now for any of the provider groups in the audience. I know from the Care First side, we recognize that payer alignment is really key in moving this forward because healthcare delivery cannot look the same as it did before this. When we think about working with vendors or with groups that are specializing in areas rather than bringing everything in-house, I think about that as like an actionable next step that we can take as a payer. So I'd love to hear from each of you just a few things that we can focus on right now. And let's actually start with Kevin and move our way down.
I'll still start with the data piece, right?
Yeah.
So, it takes a long time to come up with the data architecture and implementing it. So that's the first and foremost thing that I would think about. That's where I'd start.
Simple.
Yeah.
Love it.
I'll say three things. One, start using AI in your everyday life immediately. Have a ChatGPT on your mobile phone. It's amazing how you all personally get used to using AI on a daily basis. In a weird way, it helps with the mental blocks. A couple of other two things is tech never sake of for tech, right? Think about the most important, painful problems you have to solve, problem back versus technology back, and see where could latest technologies help, and if you made a list of your top three, where is it and could it help? And the third thing is tech is always a small part of a bigger puzzle. Change management. What does it take to changing human behavior is the hardest thing I had to deal with in my healthcare career. Hardest thing. Doesn't matter if you're talking about a care team member, patient, doctor, everybody, right? So the incentives, the training, the behaviors, processes, everything that has to go around tech is what makes you solve the pain point to begin with. So think of it as these three things and start with one area. That would be a win.
Gosh, hard to follow. What would I say? So probably the biggest one I would recommend, and this may not be 1 to 2 years, but even further out, is I do believe the patient is going to be the locus of care delivery in the future. And I think capabilities that are out there, the RPM, et cetera, it's still early. But the technologies we're talking about and the capabilities we're talking about will enable that patient to become equal to the medical field, right, around information asymmetry, the capabilities, the monitoring capabilities. Many of the things we look to the care delivery system to do will eventually be empowering the patient to be able to do for themselves. And how do you, as a health plan, think about that? Because that's where all the data is going to come. You're thinking about getting information from doctors, you're going to be needing a lot of information coming in a very unstructured way, feeding into that system in order for you to be able to really be where the puck is skating to in the future. So I'd say start looking at patient information and how you're going to start structuring your systems to handle that, because it's coming.
If I could add one more thing, your comment reminded me of the change management piece.
Yeah.
I'd say 90% of technology failures are because of change management, and their piece is process. So start understanding your processes, because if all you do is chunk technology on top of your existing processes, all you're going to do is make crap faster, right? So understand what your processes look like, map those out, and that also is a very long-term effort to really understand those in detail, and then start to marry that with the technology in a way that gets you better quality, cheaper, faster.
Thank you all so much. Thanks to all of the panelists for sharing their thoughts. I think we have just a few minutes for some questions if anyone wants to start us off in the audience. Yes?
My question is about my chart information and how that may be integral to help us to identify some of these gray areas of So trying to identify some of the gray areas with using my chart data from the hospitals in order to integrate, because I've noticed that some patients they'll forget certain medications that they're on, but if we had more of an integrative system that we could access that together in some way so that we could start collaborating more on patient care.
Yeah, I mean, I think the sad part is, right, that exists today. We just aren't doing it, right? That's the prior conversation. Like all the EHR information, I know we're trying to push interoperability standards going forward. We should be providing access. I would always say, and I think probably the three of us would potentially agree that, we shouldn't be competing on access to data. We should be competing on what we could do with the data to make care better. And so this hoarding of information around and not sharing it, I think that's what the feds were also pushing to do, to try to make sure we have access. So yes, there is gold in those information, maybe using some of the LLM models to extract all of that, because as you know, my chart, like you can have like 70,000 pages of my chart messages going back and forth. Where's the gold in that to try to find that? But and I think that's where, again, right? I mean, even today, discharge summaries, I hate reading discharge summaries, right? Because they have so much junk, and there's gold in there, but I have to find that, and I hate doing that. So that's where the technology, I think, can begin to help. Yes, my chart, probably going to need some help as you get into my chart.
And
I,
I was just going to say potentially AI, like if we can solve the interoperability, kind of challenges that we're facing, AI could potentially, help us pick out, Agnes came in, she, needs to take this medication, has these gaps, and just simplify that process at the point of care.
Yeah.
And one additional point I'll add, I agree with what you said, Joe, is also the upstream, what we do can actually reduce my chart size,
Yes.
right? Totally
Yes.
unnecessary.
Yes.
It is actually a symptom of a much bigger issue to solve.
Yeah. Unfortunately, the last I checked, the number of faxes in healthcare continues to go up. Right?
course.
So the primary means of sharing discharge summaries is a fax, which is not a digital document. It's an image. It's a piece of paper on the internet. Right? So that's some of what we're working on. For instance, we've done some work like in autism, trying to understand prior authorization requests. And all of that is, a 20-page fax that comes in every 6 months, and that says, here's what Kevin's performance was on ABAS, right? And it's a chart that's been scanned 3 times. It's horrible, right? Yeah. And you expect your nurse, who you're paying probably $150,000 a year, to review that over the course of an hour, and then you're going to approve 98% of them. Right. And she's reading one set of faxes, and ideally she's looking at the last 6 sets of faxes over the last 3 years to try to figure that out. Right, so I'm a huge skeptic of FHIR as an example, right? Because all you're going to do is push pieces of paper through a different pipe, right? Until you solve the pieces of paper problem and understanding pieces of paper, whether they're on the internet or on the fax machine, you still have a huge problem there. So and even when you do have digital data, the structure of that data is different across my implementation of Epic versus your implementation of Epic versus your implementation of Cerner. It's all different, right? So we were paying people tons of money to figure out the quasi-structured, but not really. Here's what they're really talking about. I know because the Cerner does this over there stuff. Right. Yeah.
Oh, looks like we have one.
So I'm really an interoperability passionate about so much. I was one of the folks that helped take systems live on Epic, and so I'm going to buy Perplexity garb for those of you who want to know what side I'm on. But I'm really curious about your thoughts on sensors and just moving completely to body cam and taking the EHR out of the picture altogether.
I can jump in.
Yeah.
Because I think where I'm seeing that be very interesting right now is in procedural areas, right? So video analytics around detecting things that are happening that lead to patient error and patient safety. And I know in Massachusetts, we were using that with our captive malpractice insurer to figure out, like, how do I use that data to make predictions on malpractice risk? And you're just video capturing the entire procedure, right? So you know how the entire team's operating, you know what's being communicated using the audio and the video to see what those risks are. And so when I think about that, and as my procedural colleagues start to see the impact of that, do I see that transition coming to the fact that I'm documenting that I did an abdominal exam, but I never actually touched the patient? There's opportunity in that space. There is still, of course, a lot of challenges with respect to patient privacy with that kind of information. And so that's going to be the mix of the two. But I would 100% agree, there's an untapped space around video and audio capability that we are currently storing away in petabytes and petabytes of information that can probably be mined for more and more uses if we do it right. But the patient privacy protection side is the one thing that I've seen a lot of resistance to around how do you use that. So even in the home, right? People are trying to track if you're a fall risk, and they're trying to do like IR imaging, so it doesn't feel like you've identified markers, just looking at gait and things like that. But I think it's there. I think there's going to be more opportunity to do that.
First of all, who are you? I already loved you. Seriously.
Yeah.
Seriously, that's amazing thought about is, I think one of my panelists said it, and I'm going to paraphrase it, is it's not about who gets the data, it's about how do you solve problems with the data. And you look at how the healthcare industry has become EHR maniac, and EHR stands for electronic health record. It's the health record people. And then now everybody is like overlaying, projecting their hopes, fears, deepest wishes on it, and it's a health record. Right? And the time has come that we raise above not only just everything Joe said with respect to sensors, but in every area to be able to treat it for what it is and to solve real problems above it.
By the way, I was the chief privacy officer for 20 years, so I've got answers to that question.
Yes.
Yeah.
So my snarky response to that would be, I worked for the CIA, I'm the CEO of an AI company. I know the possibility is not going to happen, right? Like, if you want to talk about change management, good luck with that one. That would be my response. Yeah.
Do we have time for one more question? All right. Any other? Or maybe everyone feels good, ready for lunch? Okay, go ahead.
Any other panelists have experience influencing the AI regulation that's happening from the government, from top down? Any experiences that you can share? Because to your point, Deepti, don't be a edge case assassinator, right? So how do you explain this to general counsel of your company, or somebody who's absolutely particular about that one last thing, right? Just any best practices on how do you actually go about influencing? Hey, we are there. These are the scope of work that we can confidently say this work, but this cannot work. Now leave it on the table for them to decide. I think there's a lot of barriers there, and if you can help us with some of those best practices, that would be helpful.
That's a very tough question. I will let them both go first.
I would say, we haven't worked at the legislation level. What I want to talk about is the governance inside a company, right? So, these Gen AI councils that are being established and such at different organizations. And so, the questions we get are things like, hey, you're going to use our data to train your model. You just saw LinkedIn is doing that, by the way, if you missed that one. So Zoom was doing it, 2 years ago. Like, someone's always doing it, right? So, what we talk about is we're not using APIs, right? We develop our own models. We're using open source frameworks. We pre-train them to the task, and then we might fine tune on your data, right? But what we do is we deploy all that on your infrastructure, right? So we're never deploying, for smaller companies, of course we do, but like the Aetna, Cignas, Humanas of the world, right? We're deploying on their company infrastructure. So the data's not leaving the customer's control. We're not taking it and using it for something else. Obviously, there's residual observations of, hey, we could do this better and such, right? But we're not training a model and taking that and then getting hallucinations from Humana data on Aetna patients. Not happening, right? So that's some of what we talk about at that corporate level from a governance perspective. That's obviously not at the legislation level.
But shouldn't you do that? I mean, that's the point of population health, right? Like, yes, it's Humana's data, but yes, it's an Aetna data, but it's same patient. Like, wouldn't you actually want to do that? Because that's the premise of the.
Yeah, but I would say it's not Aetna data. It's my data, right?
Right.
Just like the discussion on politics this time of year, like third-party candidate taking someone's vote. You're not taking anybody's vote. It's my vote, right? It's my data, right? So yeah, I agree, and there should be a consumer-focused, a member-focused, a patient-focused view of that, but there can't be a top-down version of that.
Since we're in DC, I would encourage you to be involved at the regulatory level, right? There are policy committees, there are advisory committees, there are work groups. It is somewhat painful to go through that application process, but if you can stick through it, participate in that process because it does lead to changes. Again, it does feel like you're screaming into an echo chamber several times, but if more of us are there talking about the value of that, using very concrete examples, the needle will begin to shift. If you don't participate, you get some zany things coming out of Congress at times. It's like, what was that regulation? And that then can set us back, right, multiple years as we're trying to figure out how to navigate it.
Yeah.
So please participate.
And I'll give a very pragmatic answer. When I was a C-level at Humana, the way we paid attention to regulation is very different. Now I'm a CEO of a health AI company headquartered in Palo Alto. What I do is we do enough to make sure we take the responsibility of if there is a regulation my customer is being subject to, that's my regulation. And I'm looking at what is it we need to follow to keep them safe and have their trust. Am I spending my personal energy to influence the regulation? Not yet. We're too new. I have too many things to go after. That's what I mean by depending on the chair I sit in, my answer to that changes.
Yeah.
All right. Thank you all so much. And actually, I will say from a payer side too, where, I think we're a little earlier on. We're still figuring out how all of the potential use cases and trying to swim in the same lanes, between CareFirst, Aetna, any groups, just find our voices a bit. So I think you'll see a bit more of this coming up because, AI isn't going away, right? If anything, its use is expanding. So with that, thank you all so much for your time. I know we're standing between you and lunch. Thank you to all the panelists. Hope you learned something. Have a great rest of your day.
Thank you.
Thank you.
Thank you.